Red yeast rice is awkward because it is sold like a supplement but can act like a low-dose statin. The red color comes from rice fermented with monascous organisms, and some preparations contain monacolins. The headline molecule is monocolin K, which is structurally the same as levastidin. So the fair opening is not, does natural beat medicine? It is how much active drug-like compound did this product actually deliver?
So if someone says, it lowered my LDL by 30 points, I should not laugh it off. But I also should not treat every bottle as the same intervention, right? What exactly is doing the cholesterol lowering? The rice, the fermentation pigments, or basically a statin hiding inside a supplement aisle product?
Mechanistically, monocolin K targets cholesterol synthesis in the liver. When that internal production line slows, liver cells tend to pull more LDL particles out of the blood through LDL receptors. That is why the measured outcome in most trials is LDL cholesterol, not whether someone feels different. Red yeast rice is mainly a biomarker story. A blood test changes because hepatic cholesterol handling changes. Across recent randomized trial reviews, red yeast rice or monocolin K preparations often lower LDL by roughly 30 milligrams per deciliter, with one 2024 meta-analysis estimating about a 35.8 milligrams per deciliter LDL reduction. Another review found benefit across 2 to 10 milligrams per day of monocolin K, but most trials were short, often weeks to a few months. That is meaningful, but it is not the same as long-term outcome proof.
That makes the bottle label feel slippery. If a label says 600 or 1,200 milligrams of red yeast rice, is that less useful than knowing the monocolin K amount? And in the newer trials, are we talking tiny exposures like 3 milligrams or more like the 10 milligram products people compare to statins?
A useful 2023 trial in mild hypercholesterolemia compared lifestyle alone with lifestyle plus 3 milligrams or 10 milligrams of monocolin K in a combination product. Over 8 weeks, average LDL fell about 16.8% with 3 milligrams and 26.5% with 10 milligrams. That dose-response pattern is exactly what you would expect if the active ingredient is driving the effect.
Here is the uncomfortable part. If monocolin K is levastidin-like, should people with past statin muscle pain, liver disease, pregnancy, or interacting medications treat red yeast rice as a workaround? Or is that exactly the group where supplement language can make the risk feel falsely softer?
The most plausible fit is a person with mild LDL elevation, low or borderline cardiovascular risk, already working on diet, weight, exercise, and fiber, who wants to discuss some monitored option. Several trials enrolled mild dyslipidemia or mild hypercholesterolemia populations. That is different from someone with known atherosclerotic cardiovascular disease, diabetes with high risk, very high LDL, or a clear guideline indication for proven statin therapy. A lot of positive studies are not plain red yeast rice alone. One 2024 trial used a standardized monocolin ingredient plus gamma-resinol and GABA. After 3 months, LDL fell 19.3% versus placebo, total cholesterol fell 8.3%, and HDL rose. That is encouraging, but it means the evidence belongs to that formula under trial conditions, not every red capsule online.
What about the trial that put supplements head-to-head against low-dose rosuvastatin? Viewers hear red yeast rice works, but if a prescription statin lowers LDL more reliably, does red yeast rice become a niche choice rather than a replacement? How should someone interpret a supplement that can work but still lose that comparison?
That sport result is a reminder that product variability is not a footnote. It can determine whether there is any LDL effect at all. Xi warns that supplements bought in stores or online may differ in important ways from products used in studies. With red yeast rice, variation in monocolin content can mean too little active compound to work or enough to create statin-like adverse effects.
If someone and their clinician decide to try it, what should they measure? Since nobody feels LDL particles floating around, is the honest test a fasting lipid panel after 8 to 12 weeks, plus checking whether diet and weight changed at the same time? Otherwise, it seems easy to credit the capsule for everything.
A reasonable response is pre-planned. If LDL drops enough to meet the person's risk-based goal and safety labs and symptoms are okay, that is useful information. If LDL barely moves, do not keep escalating random brands. If LDL falls but overall cardiovascular risk remains high, the conversation should shift to proven therapies. The point is not loyalty to the supplement. It is reaching an evidence-based risk target. This is where evidence compression matters. LDL lowering is important because LDL is causally tied to atherosclerotic risk, but most red yeast rice trials are not large, long cardiovascular outcome trials. They show cholesterol changes over weeks or months. Prescription statins have a much deeper outcomes literature. So red yeast rice may move the number. It has not earned the same prevention certainty.
What are the stop signs? If someone develops unusual muscle pain or weakness, dark urine, severe fatigue, yellowing skin, abdominal pain, or starts a new medication that is not a detox reaction, correct? They should stop guessing and contact a clinician, especially if they're combining it with statins or other cholesterol drugs.
There's also a form distinction. Culinary fermented rice exposure is not the same as concentrated capsules designed to alter cholesterol. The supplement version raises two quality questions: how much monocolin K is present, and whether contaminants such as citrinin are controlled. That is why third-party testing and transparent standardization matter, although even a better label does not turn it into a risk-free food.
So the clean takeaway is, red yeast rice can be real enough to lower LDL and real enough to deserve statin-like caution. If your risk is mild, your product is transparent, and your clinician is monitoring labs and interactions, it may be a discussion. If your risk is high, you're pregnant, liver or muscle problems are present, or the bottle is mysterious, the natural label should not be reassuring. Is that the honest middle?